Aloha, Hawaii. It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Hello there. Thank you so much for joining us today. I hope you've been enjoying our past programs and we'll be around for our future programs. Dr. Juliff's clinics, Vein Clinics of Hawaii, are located on all the neighbor islands. Well, on the Big Island. So actually started on the Big Island, Kauai, Maui, and now here on Oahu, where we record this show and play it out for all over the place. The things that appear on the show, obviously, are to do with doctor's practice. There's a bunch of really fun stuff. There's some cosmetic stuff, some aesthetic stuff that you'll really love by going to veinclinicsofhawaii.com and checking it out. And then we get, like today, pretty serious about the treatment of venous disease and some of the ways you can do that. And whenever you come up with something that you might like to hear or hear us expand on, please feel free to contact us by either going to veinclinicsofhawaii.com and hit the contact us button, or even send me an email to the Mike Buck Show at gmail.com here at the station, and Dr. Juliff and I will get that on for you. I have seen some really cool advertising lately. And it just so happened that when Doc gave me the papers today, by golly, it's about one of the things that I saw. And I love gadgets, and we're going to talk in this program about some of the diagnostic tools and some of the tools of the trade that have changed very, very dramatically. If you've had vein issues in the past, 30, 40 years ago, and you had some treatment, it was like Stone Ages. Today's modern day has a thing called an IVC filter. I want to think that I know everything, but I don't. That's why you're the boss. What is an IVC filter? What are we going to talk about here?
Well, an IVC filter is something that we use in sort of specific situations having to do with blood clots. And it's actually not a new concept or a new type of device. It's been around for quite a while. But I think there's been some recent interest. I've seen commercials here recently.
Sure, me too.
Concerning liability associated with IVC filters. So that's why I thought it'd be a good idea to talk about that and let people know what it is. Do they have one? And if they do, what do they need to be concerned about? Or if presented with the idea that somebody is telling them that they should have one, then to, ask the appropriate questions. But, this commercial that I saw here recently was, of course, it was a law firm advertising for IVC filter, liability.
That's the first one I
mishaps.
saw. In other words, I saw it and I thought, gee, Doc and I are going to talk about this. Is this a good thing? Because they're making it like it's going to kill you.
Well, exactly. But that's what lawyers do,
of course.
And they've gone through all their other things, so they needed a new point of interest, and it looks like IVC filters are going to be that. But they describe a lady who had a filter placed and it dislodged apparently. They say that she ended up having open heart surgery, which can happen.
Sure, yeah.
And there was a big payout. So, everybody should call them for their IVC filter mishaps.
Yeah. And by the way, my friends, let us explain that, because quite often Doctor and I talk about this, and it's because of, mass merchandising and television. And it's not my imagination. We've talked about this a lot of times before, Doc. There seem to be, I don't know, maybe 30, 40 new medicines on the market that all have these extremely creative names and they're this and that. And I guess because of mainstream media, it is the darling of things to advertise, because these companies, I guess, have a lot of money to launch their products once they got. Anyway, the long story short here, or my question, a short question of a long lead-in, is that obviously these things have a value, and this is all these ads you see. So maybe you can explain it as a physician. I see the ad; it tells me how good this IVC filter is. Planted the seed in my mind. I'm going to ask my doc about that, and then the whole minute goes by with how am I going to get chicken pox, my legs are going to fall off, I'm going to have a heart attack, and I could die.
Right.
Is that all because of these lawyers that we just talked about?
Well, that's their list of disclaimers. But it's been interesting over the past 10, 12 years, I think, where especially the drug companies have moved their marketing efforts to, rather than just trying to attract physicians and going to doctors' offices and all that sort of stuff. They're marketing directly to the patient.
Well, remember what happened though. I mean, there used to be this huge area of advertising called tobacco. And there used to be this huge thing about alcohol. Alcohol is still there, but they never drink it.
Yeah.
They never drink it on camera.
Right.
And that's part of the deal with that. But that means that, I guess, and automotive and banks and insurance companies, and now this medical profession is coming, hey, this is a pretty good way to market our stuff.
Absolutely.
What are these things?
And it makes a difference because, like you said, people do, they listen to the commercials and hear about how great this stuff is, and then they go to their doctor and insist that they be put on that as to treatment for what they have. But
what I'm fascinated about, so you can explain what this is that not just what it is, but how it's used, how it's applied, how it's inserted.
Yeah. What is an IVC filter? Well, it's one of the secondary ways that we have to protect patients from pulmonary embolism that results from a blood clot. And now we've talked about pulmonary embolism before on the show, but just to recap, blood clots typically start out in the legs and pelvis, and as a course of their evolution, sometimes a portion of that blood clot can break loose and then travel through the vein system, and goes up through the bigger veins and eventually winds its way through the heart into the lungs. And it can create problems. It can be fatal, and it's a little more common than I think that most people think.
Okay, one of the things that we've learned in previous shows are about blood clots, and often we say that many times what somebody thinks is a blood clot is that little scab that formed on their hand when they got a cut, or on their leg or their foot, and so they don't look at it as being very sizable. And what I've learned since we've been doing this program, that these blood clots in your veins can cover quite a lot of real estate. They're not these tiny little things. They're quite large.
Yeah.
So if a piece breaks, I'm guessing that it breaks off one end or the other.
Well, usually the higher part. Yeah. It could the entire clot could break loose and move.
Would you feel it?
You don't necessarily feel it until it's too late.
Oh yeah, that's not good.
Because
maybe after this program you'll be able to figure it out.
once it goes to the lungs, sometimes that's the final event. But up to 100,000 people in this country annually have some problem related to DVT-PE, and especially as it relates to pulmonary embolism, 25% of those people present with death. I mean, the way that they find out they had a PE is that they die from sudden death. And those numbers may very well be underestimated because there's plenty of people who I'm sure develop DVT-PE at home, die suddenly because it's one of the things that a patient keels over, and often most of the time we don't really know why that patient died.
Would that be something that would be found out in an autopsy?
Yeah. I mean, the only way you're going to find out is with an autopsy, and a lot of people die at home and don't get an autopsy.
I think, and this actually goes to a slightly different time. When we were talking about this before, that these things are maybe accelerated. So, but what I didn't ask you, the question I didn't ask you the last time we talked about these PEs is, let's say that somebody's a heavy smoker or a diabetic or obese or all of these other things. And let's say that their lungs are not in good shape in the first place. So is that person more at risk for PE?
Somebody with lung disease in certain situations is going to be at higher risk for PE, but certainly obesity, yes, definitely. But some other things that we've talked about before, but where that becomes important is the patient with ongoing lung disease is how bad is their lung disease and how much of a risk are they to have a PE, and IVC filters we'll learn a little later in the show here today.
And I'm once again fascinated because here we are giving this company a lot of publicity already by calling it what it is. So I'm guessing that's a trade name? IVC filters?
No.
Okay,
so IVC filter. There's a number of different
that's what I
manufacturers.
wanted to ask you.
Yeah,
And you said earlier that this is not a brand new thing.
No.
It's been around a while. That must mean there are different kinds of them around.
right. Yeah, there's a variety of different types of IVC filters. Now, when we say IVC filter, the IVC part of that refers to what's called the inferior vena cava. Now, the inferior vena cava is the largest vein that goes up
one.
and down the middle of our body. Yeah, it's the vein that runs right next to the aorta.
Okay.
So
you know what I learned, gang? Let me tell you what I learned from Doc on this. That's where all your other veins, where all the blood going up to your heart, that's where it goes. It meets there and goes through that big thing.
Right.
So that's why you don't have 10 million little things going to all the
Yeah,
places.
exactly.
It goes into that vena cava and up doing business.
Yeah, the inferior vena cava is the main highway back to the heart. As deoxygenated blood is coming back to the heart, it all from the lower part of the body. It goes through the inferior vena cava. The aorta, on the other hand, is the arterial side.
Right.
So that's the main highway from blood getting from the heart down to the body.
Would there be times that device would be used there?
No,
okay,
never.
yeah.
Not intentionally.
Yeah, okay.
That's right. Has an IVC filter made its way into the aorta? Yes.
Yeah, a rogue might end up there.
Yeah.
But I think that I want to make sure that, first of all, I was talking to Doc off the air about this, and I thought that this was something that you put in there and it stayed there like a stent or like some of these other things. Mm-hmm. But you say that, and I think people need to know the technology and the way that you actually, so hopefully sometime during the program, we'll get into the way it's actually inserted.
Yeah, we'll talk about
and
that.
removed.
Mm-hmm. Yeah.
That's fascinating.
Yeah. So now the inferior vena cava, again, as we said, it's the biggest vein in the body, and it can be quite large in the abdomen, in the lower part of the vena cava. Mm-hmm. It may be 2.5 centimeters in diameter.
That's like a baby finger.
So, even bigger, bigger than that.
Yeah.
So. It's carrying a lot of blood.
You haven't seen these baby fingers. This is a big one.
You got a big one.
Yeah.
So the IVC filter is something that we place into the vena cava, the largest vein, essentially to filter out or stop blood clots from going up to the heart.
So am I assuming that this is going to be somewhere near the bottom of the vena cava?
Right.
Yeah,
it's near the bottom.
Everything goes through there.
Yeah. So most of the blood from the lower part of the body, and more importantly, the blood clots that form that we're concerned about that break loose are almost invariably from the legs and pelvis. Mm-hmm. So all of that blood goes through the vena cava.
Big job.
Yeah.
Yeah.
So it's it stops blood clots from moving all the way up. Now those blood clots may still break loose from that deep venous thrombosis from the original position that was in the legs, but it's not going to go past this filter. So what does a filter look like? Well, a filter looks it's made out of some. There's a number of variations, but it's a network of, stainless steel wire, inert sort of metal that, again, gets placed into the vena cava, opens up, and it acts as a screen.
I was going to say, does it actually catch stuff, or is the object of it to not let it pass through?
Both.
Yeah.
Yeah, it's catching stuff.
Because, my next question is, okay, I just caught one. Now what happens?
Yeah. Well, I think that typically one of two things is going to happen. The body will break that clot down over a period of time.
Banging up against that screen, one would say, right? Get it in smaller pieces.
Well, no, the body, just the body itself will, decompose, I guess, the clot, and it will disappear, or it becomes sort of a chronic thing, and it contracts, it gets smaller, gets plastered up against the wall.
Which would give you trouble?
Depending on, it may or may not. It would depend on how much it's obstructing flow. Now, the other thing that can happen is, that filter could fill up with clot, and the entire lower part of the vena cava clot off.
Would there be a way that you can diagnose before you put the thing in there how big of one you need, or are there more than one size?
The size really is dependent on how big the vena cava is.
Oh, of course.
So, and it's not, they're not, the different sizes, again, are just, utilized according to the size of the vena cava. And it's pretty standard, but it's not like, gee, we think this patient is going to need a big, screen, so we're going to put a bigger one in to catch more clot. Unfortunately, it's not like that.
Okay, so typically, though, it does its job, you said. It either starts breaking down the clot or the clot, decomposes. How long are they left in?
That's a good question. Some are left in indefinitely. Mm-hmm. Some are removable. So,
okay.
We talk about retrievable and non-retrievable IVC filters. And we're going to touch on that a little later. Some people refer to the vena cava filter as a vena cava umbrella.
Okay.
And the umbrella, the just kind of the picture of the umbrella, opening and sort of in that formation is very similar to what many of these filters look like. So it's a apropos sort of description. So. How do we place these things? You mentioned before,
that's the part that's fascinating to me. Finding where to put it and then putting it there.
Yeah. So we have to get into the venous system, and usually we access a vein, a large vein, either in the neck, the jugular vein. Most people have heard of the jugular vein. Or a large vein in the groin. So we're going to be coming either from the top or the bottom, and placing the filter. And there are some situations where if you're going to have to go through clot, fresh clot in the groin, to place a filter in the position that you want it in, then you're going to go start from the top,
gotcha.
go through the neck,
okay.
so you don't have to pass through clot.
I think I got it now. I don't know if anybody can relate to the size. You already said the vena cava is, you can have it's a pretty big vein.
Yeah.
How long is this thing? I mean, you're putting right into that vena cava, right? In the bottom.
Yeah. The filter itself is probably 4 or 5 centimeters in length.
Okay, so a couple inches.
And again, it depends a little bit on the manufacturer. But the device itself comes loaded on a catheter. And what I mean by that is that
here we go. I get it.
It's down. It's like the umbrella is closed.
Right.
And we're able to get into a vein with wires and catheters, etc. And then we have a special deployment catheter that we then get into position, and we use X-ray, we use fluoroscopy, and typically you're going to be shooting a little bit of dye into the vena cava to find out exactly where that location is.
Gang, this is so fascinating because Dr. Juliff's office, like I said, 4 offices, Big Island, Kauai, Maui, and here on Oahu. VeinClinicsOfHawaii.com is how you find them. I know that you are, because of your practice and the number of patients that you see and do procedures on, and I don't want to say you're blasé about it, but in some respects, as a layperson, I look at this and saying, I cannot believe the complexity and what's available. And you said that often before, that 95% of your patients that are, say, 70 or older that had vein treatment 30 years ago, they have no idea what experience they're coming from.
Right. Yeah. Well, luckily, like so many aspects of medicine, the procedural things that we do have become so minimally invasive, and it's been a very, very good thing, especially for treating people with vein disease. The risk isn't there, the downtime isn't there, and the discomfort isn't there too. So we enter the groin. We place that catheter under what we call fluoroscopy. That's a fancy term for X-ray.
I was going to say nice light. You can see what's going on.
Yeah. And so once the catheter is in a correct position, then we push that filter, that device, out of the catheter, and then it pops open.
Like the umbrella.
And then lodges into position. So most of them, then you can kind of imagine having little legs. You've got the filter on top, and then the legs go down. They expand, and they're actually
they're
hooked.
adhering themselves.
Yeah, they're getting hooked into the wall of the vena cava and anchoring itself there, and hopefully not moving thereafter.
Is there a point at this stage where you can actually see what's going on? See if it's doing the catching it's supposed to do?
Well, we don't assess.
May not see the catch, right?
Yeah, we don't see the catch, but we see. We're watching it the whole time with X-ray, getting the catheter into position, watching it being popped open, making sure that it's in the right position after it's lodged where it should be. So yeah, we a big part of that procedure is making sure that it goes in the exact place, because there is a specific point in the inferior vena cava where we want that thing to reside, and that's the point at which it's going to work best and interfere with as little other things as possible.
Yeah, I'm fascinated, and I hope you are too, because when we first started talking, Doc was indicating this is very important. If you see something on television, it'll say, ask your physician about blankety blank. So I'm guessing that you and some of your peers are getting these calls, because the advertising must work. So does somebody, a new client, a new patient, or somebody that's a patient say, hey, Doc, I was just watching this thing. Do I need one of those vena cava things?
Yeah. Well, periodically we get those questions, sure. In this case, it would be a question of, gee, I have an inferior vena cava. Am I at risk for having one of the complications that, this law firm was talking about?
Yeah, but you see, I'm guessing that your patients that do have that propensity are aware of everything that's available. And that means maybe a few more visits than you had initially planned, so that you can, once you've had this, do you have the propensity of having it again? A clot's a clot, right? You don't just have one. Later on, you get more.
Possibly, yeah. The depending on what caused the original one. But, just by virtue of having had a blood clot, you are at a higher risk of developing another one over the course of your lifetime. So that definitely happens. But so we mentioned before that some of these filters stay in, some of them you plan to take out. And we call those retrievable versus non-retrievable.
Okay, so walk me through this, because I'm seeing this little tiny thing going on inside my groin, where this thing is, this maybe a couple inches long. How do you get it out? I know how it went in. It went in through a catheter, right? So is there a catheter puller? Is there something to get it out?
Yeah.
Wow.
Yeah, there's a specific different type of catheter, and the devices are such that you're able to hook them and then actually bring them back into the removal device. Again, similar to closing an umbrella. Sucking up an umbrella from the top.
And by the way, gang, we've learned in previous shows, and I hate to interrupt, but I love this because I get to tell everybody. Back in the day, this sort of venous surgery, you'd be having a general anesthetic. Boom, you're out. And now you do your little blocker, and I'm imagining this procedure is you walk in, you get the thing done, you sit down, you have a cup of tea, and you go home.
Pretty close.
Yeah, it's amazing.
Pretty close. Yeah. It's not it's not, as far as the patient goes, it's not a physically kind of big deal. They go in pretty quickly. Typically they're not going to walk home right away. We're going to observe them for a while.
You give me a ride home.
Yeah.
But the reason why I ask this is because, like I said, you do these things so often. Can you remember back to when you first learned about these things, and when everybody in the profession was probably thinking, what's exactly the deal on these things? Back when I first learned about them, again, they had been around for quite a while. So, although it's a very technical kind of device, it's very minimally invasive. It's something that was developed a while back, and it's been successfly used for a good number of years now. Does everybody that has a deep vein thrombosis need one of those things?
No.
Yeah, that's good.
So that's and that's one of the cruxes of a discussion on IVC filters. With respect to retrievable and non-retrievable, it goes to the reason why you're putting it in. And in some patients, they have an ongoing problem that they are going to continue to be a risk for DVT-PE. So in those people, you put in an IVC filter and it's going to stay with them for the rest of their life. Yeah. In others, you may be treating a situation where their risk for DVT-PE is transient. It's only going to be there for the next 6 weeks or 8 weeks.
Yeah, see, that's the main question I forgot to ask. I'm assuming, because we're instant gratification, we want you to put the thing in and it very quickly catches all the stuff and then you take it out. No, you put it there because the clot's not likely to be all there all at once. Then it comes up, it's just flying up there little by little? Or will it
either way,
will it stop a big piece?
Oh, yeah. It should stop both. Yeah. I think both happen. Sometimes little pieces break loose, and can be consequential. Other times, larger clots, move, and there can be more problems. But the filter is designed to catch all of those things. So the problem in this country, in particular, with IVC filters, is that going to your question from before. Does everybody with a DVT need a filter? The answer is no. But there was a good period of time in this country when the IVC filter was being tremendously overutilized.
Yeah, see, that's what I was going to ask you, because we talked about this in other things, on some other things. But it seems like if you are a very powerful manufacturer and you get out there, that you convince everybody that these things are absolutely necessary. What you're saying is that quite often your specialist will make the call whether or not your condition calls for that. Is it more, because it sounds like it's a little bit more invasive.
Yeah. But yeah, you're right. Yeah. I mean, and that decision is not as much in the patient's lap as it is in the treating physician's lap. I think again, it's a procedure. Doctors get paid for doing procedures, and I think it was just overutilized for a long time. And unfortunately, it was people were being not treated completely ideally. That the peak of the IVC filter use occurred in this country around 2009. So that's just 10 years ago.
Yeah.
And however, over the last since then, it's been coming down, and it's getting back to a point where it is much more appropriate. Another thing, getting back to retrievable filters, is that the other thing that happens too often is that people have a transient reason only for having a filter. A filter gets put in, and then they get lost to follow-up, and it is not taken out.
Not taken out. If it's not taken out right away, can it get too grabbed to take out?
Yeah. So ideally, you want to take that filter out in 30, 60 days. After the acute phase of their disease is over, and then it comes out easily. But yeah, the longer it stays in, the more scarred down into the cave it's going to get, and the more dangerous the extraction is going to be.
Okay, and I got one. On this show, my friends, and remember, VeinClinicsHawaii.com is how you can hook us up. Big Island, Maui, Kauai, and here on Oahu, where we tape this program that you're hearing weekly. And one of the things that we don't usually do on this show, because it's not interactive, we record it, but we don't talk about how much is it. There's no discussions of money. Everybody gets treated a different way depending on insurance. I mean, it's a very fair practice. But I have to ask, because it sounds like this thing is so exciting that they probably cost a lot. In the very beginning, anyway. And if that was the case, everybody wanted them used because everybody can make some money.
Yeah, sure. Yeah, it's like any other business. Yeah. But it's not. Frankly, I don't even know what the cost of the usual filters are. But it's not a huge expense. I mean, it's not like a pacemaker or defibrillator.
But I'm still blown away at the way medical research and testing and all goes on. So when this is out there. Now, the reason why this program is being done today is because Doc noticed, and there is a tremendous amount of advertising on these IVC filters, particularly by one company. And it's like the asbestos guys that call you up and tell you, you got to come in and this and that. And what they're really talking about is a class action suit in which you can get, they'll say compensation, all this stuff. But I don't want people to be afraid of the device because they get scared away, especially if they've had treatment more than once. Does that happen? Do you sometimes see a patient a second time for the same thing?
For this second time for the same
Not
thing.
Not the same exact thing, but another clot that's going up to that vena cava.
That would require additional filters put in, you mean?
Yeah.
Or, no, that situation probably doesn't come up very often
because,
those people that had an IVC filter put in for some reason, that it stays with them if they have an ongoing need. So it's not going to be taken out. But are people with IVC filters? Are they going to have events that that the filter being there will be beneficial?
That's next. Yeah, let's talk about that because you mentioned one woman earlier. In other words, I'm looking at this thing. If it dislodges, it's this little thing that's going to go somewhere.
Mm-hmm. Yeah. So you want ongoing protection as long as that risk is there. So, what are the indications for an IVC filter as we stand right now? So there are absolute indications, and then there are relative indications. The absolute indications are sort of across the board.
Yeah, you see them right away.
Anybody with these criteria, they need a filter. The relative indications are sort of you have to make a clinical judgment on it, but the absolute indications are a contraindication to anticoagulation.
Mm-hmm.
So if somebody has developed a DVT and there is some reason why you can't give them a blood thinner, are they allergic to it? That doesn't happen very often, but one of the problems is that blood thinners can cause other bleeding.
Mm-hmm.
So if a patient is known to have bleeding problems on blood thinners, then that's a patient that you're not going to be able to adequately treat their clot.
Because I have a little experience in that, let me ask you this. Would it be worthwhile? Let's say that somebody has a side effect, if you will, of a blood thinner. Would one try others? I mean, are there some that have different compounds where you would be able to talk to a patient and say, we know you didn't have a real good time with this. Let's try this. Take this for a day. Let's see what happens.
Not really.
Mm-hmm.
Not really. So, if they all thin the blood, and typically thinning the blood is going to have a negative repercussion no matter which kind of medication you're using. But, so a contraindication to anticoagulation when you need to anticoagulate somebody or when you prophylactically want to anticoagulate somebody. So people with trauma patients, severe trauma, they go in the hospital. Maybe they had surgery or
maybe they lost a lot of blood.
Yeah, maybe they are. And they are at a higher risk for developing DVT, or they have developed a DVT, but you can't anticoagulate that patient because they're post-op or they have internal injuries. And that's a prime example of somebody who would have a contraindication to anticoagulation. They would be a candidate for an IVC filter.
I have waited this entire program for my dumb question of the program. And by the way, there is no dumb question. Thank goodness, because otherwise I do it all the time. But if you have one, you go to veinclinicsofhawaii.com and just type in there, contact us, I've got this question. There is no dumb question. But I do know that if you are in tune with your body, and let's say that you're a rough and tumble person and you're always getting spindled or mutilated or somehow. And I've noticed that different parts of the body, blood is a little bit different, and I'm guessing it really isn't. But are there lots of different thicknesses and variances about people's blood?
No.
Pretty much all the same.
Yeah.
A transfusion's a transfusion, right?
Yeah. You mean in any one individual?
Yeah.
Different or blood from various parts of the body seems somehow different.
Yeah, I was going to ask you that. Mm-hmm. If you prick your finger, it might be lighter blood than if you gouge something. Or is it the other way?
Well, that kind of goes to how much of blood coming out is venous versus arterial. Because
yes. Doggone it, there's two different kinds.
Venous, venous blood does not have oxygen in it, so it's dark. Arterial blood is a little brighter red, so it goes with that.
I got it.
Now, the one thing that is different, depending on different parts of the body, is the amount that you might bleed. Mm-hmm. If you cut yourself, it's kind of the scalp is a prime example of that. It's so vascular that you get a little cut and you're going to bleed a lot. Mm-hmm. But the blood is the same all over.
Yeah.
So the second absolute indication is recurrent pulmonary embolism.
Recurrent.
Okay. PE, despite anticoagulation. So somebody comes in with a deep vein thrombosis. We start them on a blood thinner, and they are therapeutic on their blood thinner, and they're going about their business. And they have, and maybe they had a pulmonary embolism as part of their, initial story. It was part of their presenting complaint. So, and you treat those people the same way. You anticoagulate them. Well, then after their anticoagulation, if they suffer another pulmonary embolism, then that would be a person that you would put a filter into because the treatment has failed. So,
yeah, and by the way, failure's kind of not an option. If you go to the right doctor, if you come to the vein clinics, you're going to get treated, because I think what needs to do is what you're doing, because of the analytic equipment that we speak of all the time, it's way more, I don't want to use the word practical. It's way easier to diagnose somebody than it used to be.
Oh, yeah.
Because I remember before we talked about when you have the old vein stripping, when they rip your leg open to take this thing out of there, that they might run into all kinds of heebie-jeebies in there that they don't want to deal with.
Yeah.
But I'm imagining also the diagnostic tools that you use, primarily the ultrasound, can differentiate between the different things that it's seen.
Yeah.
If you have a good operator like you do.
Right.
Yes.
And that's what, that's what ultrasound has been able to offer to, especially, vascular physicians, is it's such a quick and easy way to evaluate arteries and veins.
Yeah.
And gives us most of the answers that we need in a very short period of time. So the third absolute indication is an anticoagulation related complication that kind of goes along with a contraindication to anticoagulation. But so a number of people are going to come in and be treated for DVT, PE. And in the course of their treatment, then they have typically a bleeding episode. Maybe they had a stomach ulcer in the past or whatever, or maybe they have some kind of GI inflammatory thing. Or
okay, so the word that's been used before that I get from Dr. Juleff all the time is complications. So obviously, there's maybe for some things a boatload of complications and some not as many. Would you consider this procedure to have multiple complications?
The procedure itself, it does.
Maybe I should say the device.
Yeah. There are complications. Just like anything, though. Like you said before, I don't want to scare people away from a filter if it's warranted, But there are multiple complications that can arise. And so, getting back to the indications, those are the three. Bleeding problem, recurrent PE, and anticoagulation-related complication. Those are the three absolute indications where IVC filters should be placed. Getting back to your comment before, does everybody with a DVT need a filter? No. But that's sort of what was happening before. Prior to 2009.
And maybe, because you say complications, maybe these ads that are going on because they've compiled a lot of the complications.
Oh, yeah.
And said, hey, there's some serious sewage available here. Let's go sue these people.
Yes, exactly. Sewage is a good word for that.
Yeah.
But, okay, so some of the relative indications, if you have what we call a free floating thrombus or clot in the inferior vena cava, or in the upper leg and pelvis. So, sometimes we can look at these clots either with an ultrasound or whatever, CT scan, MR, And we can see that the clot is not well adherent to the wall of the vein.
Okay, which means it could break an
loose.
Immediate problem. Right?
Yeah. So we look at that and we decide, how threatening that might be, and then in that situation, we might put a IVC filter in, even though they haven't had a pulmonary embolism yet.
I was going to ask you about that. I was going to ask you if, in anticipation, if you're examining somebody or if they have a clot and they come in to get it treated, is there an indication where you can tell that this has happened on other occasions, that you can look through my system with your ultrasound and say, that looks like it was, that's a clot, and it looks like it used to be bigger.
Yeah.
I don't know about that.
There are ways to evaluate how long a clot has been there.
Yeah, that's what I mean.
By looking at various aspects of what we see on the ultrasound. The other thing is that how do we diagnose pulmonary embolism?
Yeah,
well, most of the time we do a CT scan, CT angiogram, and that will diagnose pulmonary embolism. Sometimes there are reasons why we might do that, and the patient doesn't have symptoms of pulmonary embolism, and we see it. So it's good to get a baseline when we're treating people with DVT, PE. Often it's good to get a baseline to see where they are right at that moment, so that we can assess if things change in the future.
What is for those that don't know, a CT scan? What does that mean?
Well, the CT scan is that that big donut thing that your whole body slides through.
Yeah, very much like the MRI machine.
Yeah, very much like an MRI, and it gives you essentially a three-dimensional kind of picture of what's going on inside.
Which I found out when you get to see yours, it's fascinating.
Oh yeah. It makes it even more interesting when it's your own. But so what are some of the other reasons? We touched on this before. If somebody has very severe heart and lung disease, and if they have a PE, it will likely kill them.
Right.
Then some of those people would be a candidate for IVC filter.
Smokers beware here.
Yeah. If they present with just DVT. But yeah, you're right. People who smoke, they're ultimately going to have some amount of lung disease. So you have to be concerned about that. Poor compliance. Some people that are very, very poor being compliant with their medication. Yeah. Some of those might deserve a filter, and then also filters. Usually, we also put a filter in when we do the thrombolytic therapy.
Okay, yeah, I was going to ask about that too. Interestingly enough, friends, I had this guy that told me that his brother was a diabetic, and he used to always want, because he used to eat the worst stuff, and the guy always said that he could handle it, he knew what he was doing, and then they had to take a toe off, and that was the big wake up call.
Yeah,
but I'm also guessing that some people are just really strong people, or don't react to some of the symptoms that they may have, and there could be people out there listening right now that are a candidate for all kinds of treatment that just don't even know there's something wrong.
Yeah.
How do we wake people up like that? Outside of doing programs like this, I guess a lot of it's word of mouth, where somebody says, "Hey, Grandpa, what's that big lump?"
Yeah.
Or whatever.
Yeah, that. We're always trying to educate, not only patients, but the medical community that we're a part of, and doing these kind of radio shows and just trying to get out there and talking to people.
We do know, gang, that every time we do this, that somebody wakes up. But in the very, very beginning, Dr. Juleff decided that, what we're going to do is really educate somebody. We're not just ringing the bell to get patients in the door. But if you need a consultation, or if you think now's the time, here in Hawaii, you have actually 4 different offices you can go to: Big Island, Maui, Kauai, and here on Oahu. And I think that what you need to do at some point in time is have somebody inspect you to the point where you do it as often as you do other things. Like if you get your heart checked once a year, or if you go to the dentist a couple times a year. Shouldn't you just, as a rule, know a little bit more about your circulation?
Yeah, sure. Yeah. I think, as you say, the first step is to be aware of symptoms and not ignore them. Yeah. And then also, if for those people who have ongoing chronic venous insufficiency, it's a good thing to assess that on a yearly basis.
Well, it's like going to see a doctor before you need one. I remember talking to a doctor friend of mine one time that he came in. I was on in the hospital. I'd been in an accident, and he said, "How are you doing?" I said, "Well, I'm on a gurney, and you're not, so I'm not feeling so good." And a doctor, and I'm sure that you're the same, would much rather meet me before I need your services.
Sure.
You know? But I think that, once again, painting this picture is a little bit more difficult because you've said many times that this disease, chronic vein disease, is a long time coming. It develops over a long period of time. So there's never an urgency factor until you get way into it where you got some big problems.
Yeah, that is a problem for people being aware of symptoms because, in general, the garden variety of venous insufficiency, those people have ongoing symptoms that have, come on over a long period of time, and you get used to it, or you chalk it up to other reasons.
One thing that I think is significantly important, I told you early in the program, and I try to remind you every week, that Dr. Juleff also has at Vein Clinics of Hawaii a lot of really interesting cosmetic, aesthetic stuff that you do to, increase your self-esteem and all that. And I'm wondering if, when I come, let's say that I'm some young guy that's a model in a magazine and I want to get looking good, and then I come in there and I see somebody that's, a little bit longer in the tooth sitting there. I'm thinking, all right, wait a minute. This is fun what I'm doing now.
Yeah.
But this guy's also doing some serious stuff. So I'm wondering if people are, as a result of getting a cosmetic or aesthetic treatment, saying, I have this other thing. Since I'm here, can we look at that? And isn't that important?
That happens all the time.
I bet. Yeah.
When they come to the office, we have various literature and material around the office that lets them know the whole spectrum of things that we do, and at least it starts to get them thinking and asking questions, and sometimes they are very important questions, and we end up evaluating them for other serious matters.
And that's why we ought to, at this point, make sure that we let everybody know that the reason you conceived to do this was because it is being advertised and it is being, it is of concern. But I'm wondering, maybe like the percentages of people that really have a problem with this, and is that kind of scary what's being on television right now, or is it something that maybe, for instance, can your body reject the thing? Let's say you're going to put this thing in me. Can I become irritated because it's in there?
You're not going to reject it the same way that you get rejected
like
organ transplant or whatever. Sure. So no, it's an inert material, and we don't see rejection. However, what are the complications of this procedure? Let's go through those. And there's two sets of complications. One set of complications has to do with putting the device in.
Okay.
So when we put the device in, there are if we go through the neck, sometimes we see collapse of the lung, which is not a small thing. Now, how often does that happen? Yeah. Very, very seldom, but that is one of the complications. You might have injury to the vein that you're going into.
Sure.
So you might injure the jugular vein. You might injure the vein that's in the groin.
Yeah, because remember, gang, this thing is going to go. In this case, Dr. Juleff is pointed at his jugular vein up by his neck, and this thing is going down to your groin.
Right.
So it's taking quite a travel through your system.
Yeah. So you could injure, you could injure the venous system at any number of levels. Yeah. But another complication is thrombosis of the vein that you're going in. So you might, clot off the jugular vein may end up clotting off, or the vein in your groin may clot off. Persistent bleeding. We're entering the vascular system, and anytime that we do that, you might have bleeding subsequently from that procedure. And then pulmonary embolism itself is a risk because the fact that sometimes if you're using the device, you're going through the device where clot might be or nearby, and you may dislodge something, and PE occurs. So, unfortunately, pulmonary embolism, which is why we're doing the procedure, is in and of itself a risk.
So then, Doc, how do you keep an eye on what's happening as you're doing it?
Well, you just try to do things as meticulously as you possibly can. And again, we use X-ray extensively while we're doing this procedure.
And a dye you mentioned earlier.
Yeah, we shoot a little bit of dye so that we know exactly where we are and that kind of thing. So, Okay, so those are the potential complications of doing the procedure. Then we have a set of complications having to do with the IVC filter itself.
Okay, that's what I wanted to ask.
And that's kind of what all of this goes to. Mm-hmm. You can have trauma to the inferior vena cava because again, we're passing this thing through the vena cava, and potentially, I've never seen this happen, luckily, but you could tear or rip or puncture the vena cava. That would be a tremendous problem. Mm-hmm. Now, then you have internal bleeding that's going to be difficult to control. We talked about the fact that these filters pop open, and then the legs of the filter, typically they have little barbs or little hooks that go into the wall. They actually stick into the wall of the vena cava, and those little legs can actually penetrate through the vena cava.
Okay.
Now you might visualizing that, you might say, "Oh man, that's going to be terrible," but sometimes it's not. Sometimes there isn't any appreciable bleeding, and but it's something that we worry about.
It sounds like there's more success than failure with it.
Oh, definitely.
But, and so that means you shouldn't be gun shy if your doc explains that device to you.
No, not at all. There's something called filter migration. It can dislodge, and it can travel. It can travel like a pulmonary embolism into the heart. That's what this commercial was about. Filter fracture. It can become infected, but the likelihood of all of those complications, each one, is very, very low, about less than 1%.
So that's the perfect storm is unlikely.
Very unlikely, yeah. And then we talked about the fact that can that area of the vena cava clot off completely? Yeah, it can. And that happens about 5% of the time. So that's not an inconsequential amount.
I should have asked you this earlier, because I'm assuming that during this procedure to the vena cava that it's not being used, because you're doing something in there. Are there several? Is there one vena cava?
There's one vena cava.
Yeah, that's it.
There's just one.
Yeah. So that's the one we're putting this in.
Yes. Yeah. Yeah, one. 99.9% of the time, there's only one. I mean, there are some congenital abnormalities where it can be duplicated, et cetera. But in general, most people have just one vena cava.
And it seems like it's doing a pretty big job. Obviously,
it's huge.
It's very important. To me, you're saying that in the cases of which you apply this device, it's a backstop right there.
Yeah,
it's to prevent these little bits of things that have broken off to going any further and doing damage.
Right, right. So the complication rate is very, very low. I think it's in any procedure we do, there are potential complications, so I think the crux of the matter is if presented with the question or with the comment or statement that, gee, Mrs. Smith, you need an inferior vena cava filter, the question would be why.
Exactly. That's why.
And I think, the lessons to be learned here are the procedure is relatively easy to do, and it's done by a lot of different types of physicians. It's not just vascular surgeons out there doing this. And in the past, it has been overutilized. Easy procedures. If all goes well, it can be a 15-minute procedure.
Just a real quickie. I mentioned that earlier, that 95% of what you do at Vein Clinics of Hawaii is in-office procedure, and you get out of there. So, but I'm guessing, just out of curiosity, because we've talked about anesthesia and numbing. And is this done? Are you just putting in a block? Am I awake while this is going on?
Yeah, you're awake.
Yeah.
You might have a little bit of sedation kind of medication
to smiley stuff.
Yeah, to make you happy and comfortable.
Yeah.
But by and large, it's done with a local anesthetic. We numb up the skin wherever we're going in, and that's it. Yeah.
Yeah, and obviously, I mean, the level of training that you have, you're a practicing, a surgeon, that even though these incidents come up, you have plan A, B, and C right there at your fingertips. I mean, you need to be loaded up with that.
Sure.
I think it's fascinating. So, one once again, this is not to be scared away by some of the stuff you see on television, but when it comes to these IBC filters, don't just call them up and say, when can I get mine? Don't you really want to say, when can you look at me to see if I'm a candidate for one?
Yeah.
Okay, that's going to do it. Next time, we're going to be doing some more stuff. If you want to hear something on the program, here's what you do. Go to veinclinicsofhawaii.com and click in there, contact us. We'll be happy to talk back with you, or drop me an email, themikebuckshow@gmail.com, and we'll see you next time. And remember, it's all about your health. We'll take care of you.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.